We have a busy evening here and a really special one. We got some folks joining. And I just have a few announcements before I ask my Dr. Bender to come up and make the introductions. So first and foremost, I want to remind everyone that not next Tuesday, but a Tuesday after, June 4th, we are going to have a very important faculty meeting. I will be sending out a brief focused agenda in the next probably 1 to 2 days. And the focus of that discussion will be at a very high level to discuss the Aligned Clinician Enterprise and its impact on funds flow and really just to gather feedback as well as provide some information on how we are going to not only use this as an opportunity to continue to build our vision and mission forward, but to really excel in this new era. But a lot of changes ahead, and I think it'd be good for us to kind of all come together and hear it at a high level together, and then we'll have individual group meetings being scheduled in the week or so afterwards. So just wanted to remind folks about that. And then on that same week, we also have Noah Bailey Mertz joining us on Thursday to give medicine grand rounds in the morning, and a special cardiovascular grand rounds that day. We'll send those details out. And she'll certainly, help educate us on how she's moved the field forward of women's health and cardiovascular medicine and her successes at UCLA. So with that, I'm going to just move some slides forward. Hopefully remind everyone to please get your CME credit. For those in the room, I've started putting the chalk up here so that you can remember that. And just to remind everyone that next week we have fellows presentations. Both Evan and Inga will be talking about their research and what are really very impressive accomplishments that they've had over the last several years as fellows before the faculty meeting on the following week that I mentioned. And then we have no grand rounds on June 11th. That is the week, I believe, of our fellowship graduation. And then we have La Princess Brewer coming in to give the Woody Lee honorary lectureship in late June. So we have a lot of wonderful speakers. And so with that, I would really like to ask Jeff to come forward and do the honor of presenting the lectureship and introduce us to Dr. Eagle, who we're honored to have today with us.
Thanks, Eric. Welcome to Cardiology Grand Rounds. Eric, you've given me several challenging tasks since we've worked together in the last few years. I think introducing two of my favorite people in just a few minutes is definitely a challenging task. I would like to give you a shout out, though, for establishing this lecture series in honor of some of our most respected faculty who have been with us for many years, some retired, some semi-retired. I think it's added a lot to the portfolio, the repertoire of grand rounds. Okay, giants of Yale cardiovascular medicine. So this is the Lawrence Larry the Heart Cohn Honorary Lecture. And I'll describe what that is a little bit more. It's not going to be an entire life story. I would like it to be, but I'm not given that much time. But I could not resist this photo. This is a photo of a very precocious medical student, Dr. Cohn, back in the day. And this is, I believe, internship year or thereabouts. It says Grace New Haven Community Hospital. That's what our hospital used to be called. Straight medicine. Not sure that's a term we would use anymore. So I can think of actually many reasons why Larry got his nickname Larry the Heart. And I'll just mention a few. One is his name really has been synonymous with academic cardiology for more than 5 decades, really has been. Here's a newspaper article, and you can see it says Dr. Lawrence Cohn hooks up Pete the baboon with a sequence pulsator. So this is when he was chief of cardiology at UT Southwestern. I don't know what a sequence pulsator is, but he can probably answer that for you later.
Successful.
Okay. You didn't have to disclose that. And of course, he has been one of the most highly respected go-to role model clinical cardiologists that we've all known for many, many years. And many of us have really used him as a role model in that regard. And then he taught first-year medical students heart sounds. I think they still use stethoscopes, but I'm not sure. But he taught them heart sounds for 45 years. And this is a picture of Peggy Bia, one of our colleagues, giving him some gifts after the last of these sessions that he taught in 2015. And I think the name badge on the bear says Larry Cohn, MD, King of Hearts, which is a nice touch. And then lastly, but not least, Larry truly has a heart of gold. Those of us who know him know that in spades. So this honorary lecture is just a tiny, tiny symbol of all the gratitude that we have for you and all that you've given Yale Cardiology over many, many years. So thank you. Okay, and so we'll move to Kim Eagle. I'm thrilled to have the opportunity to introduce Kim, tell you a little bit of his journey. He graduated from Oregon State University. There's a wonderful story that I don't have time to go through about a summer where he was a fly fishing guide in Montana. And there were some connections there that ultimately landed him at Tufts Medical School and eventually at Yale Internal Medicine. It's a great story. We don't have time. Kim and I were interns, residents, chief residents here at Yale maybe about a zillion years ago. After that, he completed his cardiology training and his early faculty career at the MGH. In '94, the University of Michigan was able to lure him away from Harvard to Michigan, where he has been ever since. He rose through the ranks very quickly to numerous leadership positions, both at the institution as well as internationally. And I don't, again, I don't have time to go through all of his accomplishments. It's a long list. He has many awards. I actually would like to mention a few of the awards because they might be less noticed, but I think they do describe him to some extent. He won the AHA Esprit de Corps Award, that's Spirit of the Heart Award for Distinguished Achievement. He won the Global Humanitarian Award from the World Medical Relief Organization. He won the ACC Distinguished Teacher of the Year Award. And in 2021, he won the Endless Appreciation Award from the Marfan Foundation. The Endless Appreciation Award. We should have one of those here, an Endless Appreciation. That's amazing. His scholarship achievements have been really remarkable. He's published more than 700 scientific articles, 76 book chapters, 8 books. He's made seminal contributions in many, many areas. I really don't have time to go through them. I'll mention a couple, one in particular, which always pleases me to think about. So he defined the guidelines for perioperative evaluation of cardiovascular patients undergoing non-cardiac surgery. Those criteria became known as the EAGLE criteria. And for all the trainees, you probably don't know them as EAGLE criteria anymore. They've been updated, but what Kim established certainly laid the foundation for what we use all the time in clinic and in the hospital. And he's defined guidelines for evaluation treatment of patients with thoracic aortic disease. And I think we're going to hear a lot more about that from him, which is a better source, in just a moment. I have to stop somewhere. I'll stop there and just say that this is my honor and pleasure to welcome you back to Yale and to introduce you, Kim. So welcome back.
So let me first say that when I went to Tufts Medical School, my mentor said, you got to go to Yale. I went to Yale, and it's the greatest experience in the world. And I ended up being very fortunate to get a sub-internship on the Winchester service in 1978. And my attending was Larry Cohn. And three things happened. I fell in love with cardiology, I fell in love with Yale, and I fell in love with that man. And he's been a lifelong medical father to me. We talk on the phone often. I share challenges I have with him, and he helps me. He is my ombudsman, as he is to the entire medical campus. When I had a chance to go to Mass General for my residency after medical school, I said, no, I want to go to Yale. I want to train under Larry Cohn. And I'm so glad that I did. And for my lifetime, I will be grateful to you. And of course, I had the chance, like many of you, to train with amazing colleagues, and Jeff Bender became a lifelong friend too. Yale has a remarkable place in the history of medicine, in the history of cardiovascular medicine, and certainly in my heart. I will always consider this to be my headwaters. And I came from a fishing family, so headwaters means everything to me. Okay, so thank you, and I'm just delighted. And the faculty I met today, Eric, holy cow, amazing people, great human beings, great spirit. I'm really impressed with what I feel today in my day with you. And I was here a few years ago when things were darker, and you've clearly emerged and are exploding with possibility. And I celebrate that today. I really celebrate who you are and what you're going to be, and you, Eric, for what you've done. So I've chosen an impossible task. I have I don't know how many slides. I will skip slides today because there's way too much content. I looked at my lecture on the plane and I said, what were you thinking? So I will skip over some stuff. If you want my slides, I'll just send them to you. keagle@umich.edu. Okay, I'll send you my slides because I will go over, I have to go faster than I would like to. All right. All right, here we go. So we're going to talk about acute aortic syndromes, and these are my disclosures. I want you to be aware that when I talk about endovascular therapy for aortic disease, some of our funding has come from industry. So that would be a particular area for you to be circumspect about my enthusiasm for stent grafts. Okay, you should absolutely know that. And if you know of any areas of industry that are funding aortic research, please send them my way. So we'll talk about where we've been in the first half of a century in aortic care, and then we'll talk about where we're headed. And I think that hopefully you'll have a sense that we're just beginning to see where we could get to right now. We all see patients with acute aortic syndromes, and we look at their clinical presentation, and we sort of look at their predisposing conditions, and imaging and the X-ray and physical findings are still important, EKG, routine labs. We put all this together. Many of these patients get an intervention, and then they get a long-term follow-up plan. This is not personalized, and I'm going to argue through my talk that we need to get more precise in virtually everything we do. But this is where we are for the most part. You know, this is a rare disease. It's about 6 per 100,000. I live in a town with 110,000. We see 6 or 7 dissections a year. So no wonder it's missed all the time. It's rare. Most of these patients have hypertension, many of them smoke, and most of them have not only hypertension, but poorly controlled hypertension. Acute aortic syndromes is not just dissection. It's actually 4 conditions. We're excluding traumatic, okay? So there's classic aortic dissection, there's intramural hematoma, which is less common, shown here. And then there's this thing called penetrating aortic ulcer, and then a discrete dissection, which is even more rare. And I have just a figure that shows those. Probably the most important one for you to think about is intramural hematoma. And these can present just like classic aortic dissection with acute onset of thoracic pain, but it's thought to be due to a hemorrhage in the wall, not a tear of the intima like classic dissection is over here. And I won't spend any time on penetrating aortic ulcer. It's much more rare, and that time doesn't permit a lot of effort there. So the classification of dissection has evolved, but this is the Stanford classification, and I like it because I'm simple-minded. A means ascending. B means A is not present. Okay? And I'm a simple-minded person. Okay, I can get that. And if you give me 3 like DeBakey wants to, or the ones I'm going to show you next, it's a problem for me. All right? I like just A and B. That leaves the arch in no person's land. And the closer you are to the ascending, the more it acts like A. The closer you are to the B, the more it acts like B. That is what we've learned as we've studied arch entry. And then this is the current anatomic classification where you can define the tear location from the aortic segments from 0 to 11. And here's one that starts at segment 0 and finishes at segment 5. That could be called an A type 5. Surgeons and interventional radiologists find this immensely interesting. I find it to be somewhat boring. Okay, and the next classification you're really going to love. This is the TEM classification, and it further divides dissection into whether or not there is malperfusion and where that's at. If I was an interventional radiologist, I would have this memorized. I would probably wake up at night imagining how magical it is. I don't use it at all, but I think it's useful for some. All right, so for years we classified dissection according to time as if you have a presentation and you're seen within 2 weeks, that's an acute dissection. And if it's beyond 2 weeks, then we'll call it chronic. And that came from this study, which was done when I was 3 years old, actually. And these investigators were like Darwin. They showed that if you could survive 14 days with a dissection, then you might survive a while longer. Okay? This is before we had treatment. Important to look right here. These early hours are really important, aren't they? Okay, so this was the classification system. 14 days or less acute, after 14 days chronic. I want to suggest to use the IRAD classification. Now that's selfish because I helped found IRAD. But if you look at type A dissection or type B, these are medically managed patients. Look at the mortality in the first 24 hours. It's almost 20%. I call that a hyperacute dissection. Over the next 6 days, you lose about 20% more. And then over the next, say, 3 weeks, you lose a bunch more. If you survive 30 days with a type A dissection, you're going to survive a while. You're incredibly Darwinian. You're going to beat the dinosaurs. So that first period of time is most important. That first day, the hourly rate of death is 1 to 2%. It's really high. All right, the demographics are known to you. Average age 65, hypertension is very common, probably 80%. An important part of this slide is the fact that Marfan, although a common cause of dissection in our minds, is actually responsible for only about 4%. This will be take-home lesson number 1. Prior heart surgery is a predictor for aortic dissection. And it has multiple reasons. One is you had a CABG, they cross-clamped your aorta, they put stent grafts into it, vein grafts, and that aorta was weakened. Or you had an aortic valve repair and it was bicuspid 20 years ago, and now you have the aortopathy. Prior heart surgery as a predictor of dissection is 4 times more common than Marfan. The other one that's sobering here is the iatrogenic one. That's caused by one of us, right? Why would I study aortic dissection? My first week as a fellow, I dissected an aorta with a wire. I was in the cath lab. My faculty mentor was in his office watching this little tiny screen. I slid a wire all the way up to where I thought the right coronary orifice would be. I slid a catheter up there and I did an injection, and there was little blush in the wall of the aorta. And I heard him go, "Oh." And both the patient and I were interested in that. And he came running in and he stat paged the cardiac surgeon, and I had dissected that patient's entire aorta with a wire. It went smooth as butter. That's what they taught me it should feel like. Well, I got real interested in dissection. The next day, I had another dissection come in that wasn't mine. I didn't cause it. But I sort of fell in love with this problem and have been studying it ever since. That was in 1983. The problem with dissection, of course, is how rare it is. This slide shows you 42,000 patients studied. Only about 0.3% patients with chest pain had dissection. MI is 100 times more common. PE is 20 times more common. Many people have never diagnosed an aortic dissection. Accordingly, if you see it, you may think its hoofbeats are from a horse, not a zebra, and it's missed all the time. I love this. This quote came from Paul Dudley White, his single author textbook, 1944. The pain in the thorax or back comes suddenly at its maximum. The most important test for aortic dissection is the history. And the most important historical fact is the onset of the pain. And if you get the patient secondhand, they went to Greenwich or someplace and then they got transferred, and you don't ask the patient, "Ma'am, tell me how it started." MI pain is not like that. Now, PE pain can be, but it's usually pleuritic. MI pain builds over minutes, right? Dissection pain is a moment. And most patients, if you say, "Tell me how it started," she'll say, "I was brushing my teeth and I dropped the toothbrush. It hurt so bad. I sat down immediately." So this historical clue is really important. Paul Dudley White founded the cardiac unit at Mass General, where I trained. Abrupt onset of pain among the markers is the most consistent one, and many of the rest have had syncope, which was my first clinical research love, founded at Yale when I was an intern. I studied syncope with Jeff Bender. We had a study called Syncopizza, where if a junior resident filled out a data form for me, I ordered them a pizza on the spot. Wasn't that great fun? It was great. So abrupt onset of pain, remember that. Abdominal pain is not uncommon, and it's often not thought of. So if you would just have abdominal pain, many of those patients get missed. Most physicians think about thoracic pain and they don't reflect on the fact that sometimes it's just abdominal pain, even type A dissection. The physical exam is so important. A murmur aortic valve insufficiency is seen in 26% of type A's. The valve is disrupted, and a pulse deficit is seen in about a third. So if you don't examine the heart and you don't listen to the heart sitting forward, and you don't do all the things that Larry Cohen taught us to do, you can miss a key clue in this diagnosis. So the way we think about dissection now is sort of this algorithm. We think about high-risk conditions, Marfan, a family history of aortic disease, known aortic valve disease, aortic manipulation, could be surgeon, could be cardiologist, thoracic aortic aneurysm. And then the pain features, especially abrupt onset and severity, and then the exam, pulse deficits, systolic blood pressure differential, focal neurological signs, AI, hypotension, or shock. So if you were in an ER and you asked that panel of 13 questions, how many patients would have none of them? Only 9%. So 91% of patients are going to have at least one of them, and many have 2 or 3. And of those 9%, half of them have a wide mediastinum on their chest X-ray. We currently think that dissection is missed about half the time when patients go to ERs. This simple algorithm should allow us to find about 95% if we follow those simple criteria, which are in the thoracic aortic guidelines. The chest X-ray is abnormal in most, but it's normal in 30%. How can that be? Bender rips his aorta and he has a normal shadow on X-ray? What the heck? The EKG, we would love it to be normal because it would move us away from coronary disease, which is so more common. But it's not normal very often. It's often abnormal. It may show ischemia. It may show nonspecific changes. It may show an infarct because the patient has knocked off a coronary ostia, or the stress of a blood pressure of 250 is causing an MI, or the stress of a blood pressure of 80 is causing an MI. So the EKG is often abnormal, and in 8% of patients, they have a new infarct. This is really amazing to me. There are a lot of people out there who have big aortas, and we don't know if they really have a disease or not. Do you care for any of these people? Holy cow. I have so many patients in my practice with aortas of 4.1, 4.2, and we don't know yet if they're really at risk or not. And so we follow them according to a cookbook that Eagle helped to write. So you need to image, if they're between 4 and 4.5, you need to image at least every 2 years. If they're 4.5 to 5, you should image them every year. And we need to get better at that. We really do. This is the sobering category of IRAD. And that is when we studied the size of aortas that tore for type A dissection. Almost 60% of them were less than 5.5 centimeters in diameter. And quite a few of them were normal. This explains the normal chest X-ray. You can dissect a normal-sized aorta. We have to, in our minds, separate the notion that only aneurysmal aortas dissect. Not true. Some families have great big aortas and they never dissect. Other families have small aortas that all dissect before age 30. That's called genetics. And so this is a very interesting thing that we have to relearn. We've sort of grown up in a culture that says, well, you're not going to dissect until you get bigger, and we don't operate until you get big. And that is all changing as we start to understand the fundamental genetics and biology of this problem. So most of the time, type A, we're going to the OR. Type B, if it's complicated, we're going to usually do endovascular therapy or surgery if there is not an endovascular option. That would be the current treatment. We're getting better. The IRAD group has studied dissection for 25 years, and the mortality has gone from 24% to about 16% overall. And if you look at type A, the mortality for operated patients is now much, much better. We've gotten much better. If we look at operated dissection around the world, the operative mortality today is about 13% worldwide, but Yale's probably in the 7% range. Michigan would be about that. Great aortic surgeons great perioperative teams, much better survival for type A dissection. It's been wonderful to follow this with our IRAD group. Patients who do poorly often are malperfused. And if you look at the frequency, this is type B dissection with malperfusion, I'm sorry, type A, coronary 26%, coma 32%, a neurological deficit like spinal cord 21%, visceral malperfusion 40%. So when you have malperfusion, the mortality just goes way, way, way up. And if you look at patients who have multiple beds of malperfusion, their mortality is a coin flip at a very short time frame of 30 days. So malperfusion really defines the risk. And now we have to think about how we manage it. For type B acute aortic dissection, uncomplicated is shown here. And these are the high-risk features that we think about. Pain, hypertension, obviously blood in the pleural effusion, that's worrisome. Big aortas, malperfusion, entry tear location, and then false lumen size. Stent graft therapy has changed the game in type B dissection. This was the earliest trial comparing optimal medical therapy and TEVAR, and it suggested in a small number of patients at 24 months that the group that got a stent graft did better. And if you examined that therapy, it's shown here. And if you examined what happens, a stent graft allows the false channel to get smaller and the true lumen to get larger. And we think that that reverse remodeling of the aorta will prevent future complications. That's the logic of using endovascular therapy. Prevent immediate rupture, prevent extension, and prevent further remodeling that leads to late aneurysm formation in the false channel. When we studied this in the IRAD registry, type B, we did see evidence that endovascular therapy seemed to be better. And I'm happy to report that there are now 3 randomized trials in stable type B asking this question: should we routinely provide endovascular therapy for anatomically appropriate candidates with type B dissection? Michigan enrolled the first 2 patients in that trial in the IMPROVE AD trial just 3 weeks ago. The largest study is here in the US, and there's one in Denmark and one in the UK. So 5 years from now, we'll know if you should be referring stable type B for endovascular therapy plus optimal medical therapy or not. And this shows you an example of a really nasty type B, very large false channel with a beautiful result from endovascular treatment. Remember, I have received funding from companies that make stent grafts. So how do we follow these people? Well, we treat them, we surveil them, and then we educate them. The probability of reintervention for these patients is high. At 12 years, it's 40%. This is why we follow them. I like to tell my patients, I'm sorry to tell you that your disease of your aorta is for life. And you and I have to manage that problem for life. It is not an event that we got you through. Yes, it was a storm, but the weather pattern is not kind if we don't follow you carefully. Patients don't like to hear that, but it's really important that we get their attention, and I'll show you that in a few minutes. If the false channel remains patent, they do worse. Now, why is that? It's because the false channel doesn't have the normal amount of elastic tissue left to buttress the wall, and it is more likely to expand and rupture over time. So if it thromboses, it's going to be stronger and it's less likely to rupture late. So we should probably be changing our imaging protocols if you have thrombosed your false channel. Right now, the guidelines don't do that. They don't do that. If you have a great big entry tear with your type B, that's bad. This shows you the size of the entry tear. If it's more than 1 centimeter, they do worse, of course. Much more flow into that false channel. If the aorta is bigger, that's bad. But look at the sizes here. This is just looking, I think, at 40 millimeters, 44 millimeters. I have a lot of patients with type B who are bigger than this. Our operative cut point or endovascular cut point is like 60. And yet we have data showing that at 44, your risk goes way up. So we're sitting here waiting to see if these trials suggest that we can be more nuanced in who we stent graft. If everybody gets better after a stent graft, great. But if there's only a cohort that gets better, it may be this group. The aorta was bigger. It wasn't at the point we operate, but it was clearly bigger than it should be. I hope that we get some more science here. The patients with Marfan syndrome, we want to be very aggressive with their medical therapy. And this is for their aorta at any size. This is just a slide suggesting to you that both ARB and beta blocker together is better. So our patients with Marfan syndrome, we want to treat aggressively with these two medication classes if we can. Now, we translate information we have in genetic aortopathy to other aortic conditions. It's not fair. It may not be true. But we end up saying, listen, if I have a big aneurysm, I'm going to treat it with a beta blocker, and we're going to use ACE or ARB to try to reduce further the blood pressure to a low point. And I've just gone through that. Okay. Blood pressure control for survival in dissection survivors is massively important. It is more important than the drug class. This study looked at patients over 10 years and looked at those who had good blood pressure control versus those whose control was not good. And there was a massive difference. We must tell our dissection survivors, you've got to stay on your medicines. How many of your patients show up to clinic and somehow they're off their medicines? It happens all the time. Well, doc, you changed my appointment. And so my medication didn't get renewed. Okay, so it's my fault, isn't it? Our systems don't do a good job with that. Patients with aortopathy, you have to tell them, listen, ma'am, you can never go off your medicine. If you run out, don't wait for your appointment with me in a month. Call me. Get a hold of my nurse. I can't have your aorta exposed to a hypertensive surge when it was repaired 5 years ago by this great surgeon at Yale, this Eleftheriades guy. It'll rupture. So these patients have to be on their medicine. There's a couple of caveats that are interesting related to aortic disease I mentioned. One is that calcium channel blockers probably should not be used in Marfan patients who have a native ascending aorta. In Marfan mice, calcium channel blockers cause the ascending aorta to dilate and rupture. Okay. And I'll show you studies from human beings, which are more important because we treat more of those, suggesting same. The other interesting group is the fluoroquinolone antibiotic class. We know one of their complications is tendon rupture, elastic tissue degradation. There appear to be a group of patients where the aorta is sensitive to fluoroquinolones. So if you have a choice in patients with aortic disease, try to avoid that antibiotic class. And there are studies in both humans and mice consistent with this. This is the data from the Genentech registry showing that if you have Marfan syndrome and you get a calcium channel blocker, you are 12 times more likely to dissect. It's a big number. And here's data on the fluoroquinolone story. And the odds ratio isn't super high, but it's about 1.7 to 1.9. It's real. It will make Kim Eagle. Kim Eagle, by the way, has a slightly enlarged aorta. If I get prostatitis, I'm going to probably not choose a fluoroquinolone. I'll try to get my urologist to give me something else. So long-term, we want to use beta blockers to manage DPDT, and then ACEs or ARBs. And here's our goal. Our most aggressive blood pressure goal in all of cardiology is aortic disease, and particularly dissection survivors. Love to get them under 120 systolic. We want to avoid heavy lifting or straining, and this may affect our occupation, and then serial imaging. And this is important. That first year after they've dissected, especially if the false channel is patent, we don't know what's going to happen. We don't know if they're going to expand that false channel quickly or not. So we want to recommend imaging often. The US guideline said 1, 3, 6, and 12 months. The European guideline said, well, 2 and 6 months is good enough, but don't lose track of them if they have a false channel that's patent. So we talked about beta blockers and ARBs and then other antihypertensive medicines. Okay, let's go then to the next part. So let's talk a little bit about these 4 areas, and I think they're pretty interesting. I'll talk to you about genetics, about biomarkers, and about imaging. And then lastly, and maybe most important, is survivorship. So you're all familiar with kind of the classic genetic conditions that we all thought about for years: Marfan syndrome, Loeys-Dietz, which are the TGFBR1 and 2 mutations, Ehlers-Danlos, COL3A1, and then the Turner's group, right? We've kind of known about that. And then since Jeff and I trained, a lot has happened in this space. And now we have these genes in the extracellular matrix or TGF-beta signaling or the smooth muscle cell area that are known associates of familial aortopathy and dissection. This library is now about 30 genes and growing every month. And that's really exciting. We start now to have an emerging science to help us with families that appear to have significant aortic disease in the family. If we look at the Montalcino Collaborative, which is the largest non-Marfan related collaborative looking at aortic disease, the most common is ACTA2. This was the gene that John Ritter had, SMAD3 at 20%, TGFBR2. So this story is unfolding right now, and increasingly it's going to be important in practice. If we look at young people who have dissection, they don't have a known syndrome. 10% of them will map to a known gene. So we want to screen young patients who have dissected because the yield is 1 out of 10. If we get a hit, then we know we need to screen their first 3 relatives. If we don't get a hit in a young person, I'm probably going to do imaging of their children at least, particularly type A. I'll probably look at their aortas. This needs to be clarified further. Here's another group of 240 patients with dissection that we studied, and we found, again, about 26 or 10% of them had one of these genes. And very interestingly, FBN1, that's the Marfan gene, was the most common, but they didn't look Marfan. And this is the interesting thing of this whole story is in the genetic disorders, you don't necessarily always carry all of the phenotypic manifestations. And you can have a Marfan genotype and a Marfan aorta and normal lenses and normal joints and normal bones. Okay, it's really, really important to recognize. And this has led to, thankfully now, a more personalized approach. In families, depending on the gene, we will have a different cut point for surgery. And here's one, PRKG. If Eric came to our place with a dissection at his young age, say 35, and he dissected a normal-sized aorta, and his sister had the same gene, we would offer aortic replacement surgery for her with a normal aorta. So you see now what's beginning to happen. And when you take a history from a patient, if they say, yeah, my brother died of an aortic problem, you want to get the postmortem. Why? Well, we want to know if it was a rupture or dissection, and we want to know how big it was. You know, if you dissect your aorta at 4.2, that's important for your brother. That will change our thinking. It'll be much more personalized. So it's not just the genetic disorder, but it's also how it is penetrating in that family, right? I sound like a genetics person. I'm not, but it sounds good. BAV, that's different. Bicuspid aortas generally act like they're not genetic. Most bicuspids don't dissect small, but 5 to 10% of BAV patients will find another gene in if they have an aortopathy. So if I find BAV and enlarged aorta, I screen them because they may have a Marfan gene or a SMAD3 or an ACTA2. That's really important. Okay, so these are the surgical cut points that are now in the guidelines, and they're showing a personalization, which is great. Another important thing to recognize is that, you know, the family history of aortic disease now, about 30% of them will map to a known gene. So we want to screen all of them. Dissection at a young age, I talked about. If you get a patient in your clinic who's classic Marfan, and you screen them for the FBN1 gene, 10% of them won't have it. What they probably have is like a copy number variant or a duplication or a deletion, and you don't dig deep enough to find that. So commercial testing is not perfect. Kim Eagle assumed, well, anybody who looks Marfan is gonna map to the FBN1 gene. Well, we had 1,000 patients in the Gentac registry with Marfan. 10% of them were negative. They had Marfan syndrome, but our genetic screen didn't find the gene. The testing's not perfect. So this is also important to us as we think about advising families. So I think what I'm gonna say about this is simply that bicuspid aortic valve, we want to think about aortopathy. Everybody we see with a bicuspid valve, we want to look at their aorta, and we want to look at first-degree relatives. If you look at a family of somebody who has bicuspid, you'll find a hit. Somebody in the family will have it about 25% of the time. Individually, it's about 5 to 10%. The other thing that's important, Larry may have a bicuspid valve and a normal aorta. His brother may have a tricuspid valve and an abnormal aorta. So there's not one-to-one correlation between the valve and the aortopathy, and the genetics of that you're working on, right? You're going to solve that for us. Thank God somebody is. We need that information. We still haven't gotten here, and that is, can we do GWAS studies to look for more common genes that, along with hypertension or some other environmental factor, predicts risk? That is the next frontier. And we're not there yet, but we're getting there. Okay, I'm going to go past this in the interest of time. We talked about how important imaging is. And this study actually asked the question, how well do patients follow the guideline recommendations for imaging follow-up? And this study showed that by 8 years, less than 2% had been seen at the appropriate intervals for follow-up imaging. Patients who've dissected aren't getting their medicines. They run out, they go off, and they're not getting imaged. They come to the great Yale, they get fixed, and then they go off to someplace, and they're not followed. So this is a really important chance for us, and I think we need to try to systematize this across all Yale facilities. How do we make sure our dissection survivors are being followed? That's a network challenge, Eric, right? It's amazing. So is there a biomarker? There's a lot of candidates, right? They're shown here. And we've been through all of these over time. And thankfully, we have one that's sensitive, and that's D-dimer. D-dimer in dissection is off the charts. Why? There's a lot of clotting going on in a torn aorta. The sensitivity is 98%. An elevated D-dimer is immensely sensitive for dissection. I've only seen a couple patients who had small intramural hematomas that didn't have positive D-dimers. Now, obviously, it's not specific. PE, they can have it. MI with a clot, they can have a high D-dimer. But most every dissection will have an elevated D-dimer. We need to get this word out and used in our emergency rooms. And this slide just talks about that, but in the interest of time, I'm going to move by it. Other biomarkers for chronic dissection are out there, but we don't have one yet that really defines where we want to go. I want to focus a little bit on imaging. We sort of have used imaging in a static way. Your picture today, the size today, the size in a year, the size in 2 years. That is so dinosaurish. We haven't taken advantage of our imaging capabilities at all. As the aorta changes, it predicts probably what will happen. And we need to get better at that, using that information. This is a study we published many years ago that asked the question, if you have a type B dissection and you partially clot the false lumen, what happens? And what happens is you basically create an endless loop up here, and this false channel is more likely to dilate and rupture. So this is the use of serial imaging to predict risk. Here's a physician I cared for, and this was his aorta 1 year, and the next year he came back, it was 4 millimeters bigger, and he had partially thrombosis. You see his true lumen is much smaller. We gave him an endograft to prevent that false channel from dilating any further. When you think about a type B dissection, blood has to flow in here and then flow out. If you actually look at flow patterns into and out of the false channel, you can actually predict risk. And the ejection fraction of the flow in and out of that aorta predicts risk over time. If your aorta starts to lengthen, it becomes this funny roadmap through Yellowstone Park. Longer aortas are higher risk. Also, interestingly, carotid tortuosity predicts risk in patients with aortopathy. What's going on in the carotid? There are areas of weakness leading to curvature and areas of higher risk. These are all areas of imaging that are under active study that I think will help us as we go forward. And dynamic imaging really offers a possibility. This is a dynamic MR looking at helicity in 3 dimensions. And this is what you and I want. This is beautiful laminar flow in the aorta. This is what you don't want, which is a tornado in your ascending aorta, and that predicts growth. That helicity predicts growth over time. So the ability of dynamic imaging to start to define fluid dynamics and how the aorta is responding to the injury will offer us the chance for more personalized care in the next 10 years. So from size to susceptibility, these are data from our place looking at vascular deformation and asking the question, how do various aspects of this aorta respond over time, and identifying hot points that would suggest higher risk. Here's an example of a patient with Marfan syndrome and type B dissection, looking for areas, regional areas of growth. This is another example of a patient with a CT at stage 1, and here we are at stage 2, where this aorta dissected. We think that vascular deformation mapping, possibly like searching for the vulnerable plaque, may predict future risk and lead us to say, yeah, that person, we should probably stent graft. That person's aorta is acting tame and quiet. It's okay. It's going to be fine. That's the future, I think, of imaging. And here's another example. Lastly, let's talk briefly about survivorship. I don't think as a medical community, we've done nearly a good enough job of helping our patients understand how to live after they've dissected. Maybe you could say we saved their life. We gave them advice. But the question is, okay, doc, how do I live? How do I live? When we surveyed patients in our dissection registry, fully 40% were disabled from work. They were too afraid to work. Almost 3/4 said, I'm not going to have sex again. I'm afraid I'll die. Depression and anxiety were present in a third. And almost 3/4 said, I didn't get clear recommendations from Dr. Eagle about what I could do. And I'm afraid. I guess my aorta is okay, but I'm afraid. We need to get much better at this. And if you ask patients, what do they want? They'll say, I want the right educational resources available for doctors. I want to figure out what dissection genetic testing would mean to me. How much exercise can I do? How much exercise should I do? And when should surgery happen, etc. Our patients are confused, and we haven't created an excellent science in survivorship. We published the first randomized trial of moderate exercise for dissection survivors last week, and it shows that moderate exercise appears to be quite safe in patients who've survived a dissection. That's good news. We can tell them at least that. You probably don't want to play rugby, but walking in at a high rate is probably good. Don't compete, but live. This is a website that I recommend to you. It's with the Marfan Foundation. Our GenTech Alliance now is under the umbrella of the Marfan Foundation. It's interesting. King George is the first description of an aortic dissection back in 1760. So he had a classic type A dissection. The story was his valet de chambre, which I guess is his servant, gave him his morning chocolate. And then he went to the Louvre to have a BM, and a mighty wind, and he dropped. How many years later are we now? I feel like we're just at the start of the story. If you think imaging, we're just getting started. Genetics, just getting started. Survivorship, we haven't started. Charcot said, disease is very old, nothing about it's changed. It's we who change as we learn to recognize what was formerly imperceptible. I want to thank, there are 60 sites around the world that contribute to our IRED registry today. We have 14,000 patients, and we're continuing. Each one of those patients' story is living science. Our patients are telling us the story, and everything we publish is in their honor. We are honoring their journey with our work. This is the university group that I work with, and they're just stunningly amazing people I learn from every day. Osler said, there's no disease more conducive to clinical humility than aneurysm of the aorta. And when I give my lectures, I like to talk about why I have the chance to be here. And on the left side are my mentors. And the top one is Larry Cohn. I absolutely adore that man. Everything that I do in clinic, I pattern after my year working at his elbow in clinic. And I think about all of you. I had the privilege of training at Yale. I learned excellence by being here. And as you go on in our journey, the academic sorority and fraternity is wonderful. It's a lifelong story of friendship. And every time I come back to a place like Yale, I feel the energy, and it lifts me up. And I hope a few of my comments have been helpful to you today. And thank you for inviting me.
Dr. Eagle, wonderful talk. I'm wondering for biomarker perspective, do you think the inner diameter to wall thickness ratio could be a more objective way to think about dissection? Because if the inner diameter is bigger but the wall is thicker, so it doesn't matter. So it's all about perhaps about ECM collagen strengths that will determine the.
Sure. What a great question. So your
second follow-up is what do you think about whether endothelial cells, one small muscle cell give abnormal signal. So endothelial cells, usually they are most sensitive to abnormal environment. What do you think about using endothelial cells as an early biomarker? Thank you.
So I love your question. And I think as imaging allows us to understand structural integrity and defects in the elastic elements of the aorta, we will get better. I don't think we're there yet. And certainly the stuff I'm seeing with our vascular deformation mapping, suggesting little areas of change in aortas that are not particularly big, but this little region starts to show an outpouching. Ooh, there's probably a problem there. The elastic elements there aren't right. So I think we need people like you to figure that out. And I hope you'll tell me when you do.
So which kind of patient do you image their brain for brain aneurysm? And do you do that routinely for bicuspid also or not?
I will if there's any family history of a bleed or an aneurysm. For, some like the Lois-Dietz, we screen them all frequently. The SMADs we're going to screen. And the relationship between brain disease and aortic disease is complicated. It's clearly genetic. And I think I don't have a definitive answer for you. Do you screen them all?
I mean, I had a case actually that was very unfortunate that I didn't have vein dilation, had only bicuspid valve, and then bled from aneurysm on the head without aneurysm of the thorax.
Okay. Yeah, and what I wonder about that patient is if he's one of those patients that had another gene. When I find aortopathy with bicuspids, I'm screening them all because, okay, so you screen them for aortopathy. Okay. So you had a bicuspid valve and a brain bleed. Okay.
Hi, I wanted to ask you a little bit more, to say a little bit more about about exercise. There are so many disease entities, genetic entities, where longstanding wisdom about avoiding exercise has not actually panned out in studies. And so I'm wondering if there are any actual data and where you see that going.
Yeah, so great question. So as far as I know, the randomized trial that we published last week is the first randomized trial studying moderate exercise in dissection survivors. So you should email me and I'll send you the paper. Okay, it's in press, but it's not yet out. keagle@umich.edu. The data supporting avoidance of more extreme exercise is circumstantial, right? I think John published a paper here where he looked at like 35 patients who dissected and asked the question, what were you doing right before your symptom? And he showed that there was an unusual amount of very vigorous activity, axe, digging ditches, things like that. But about half of them didn't have that. They just dissected. So we think extreme exercise does increase the risk. And of course, if you study what happens to blood pressure with different forms of activity, probably the worst you can do. Do any of you use salt? Do you have salt filters where you have to filter your water in a well? The salt's 40-pound bags, right? So when I lift two 40-pound bags and walk and I do this kind of exercise, my systolic can double. I'll go from 120 to 250 doing that. That's not good for an aorta, right? It's not good. So we don't want our patients to do Valsalva maneuver and, that kind of thing where they're straining like that. That's probably the worst. Light aerobic activity is probably good, right? By and large, that's going to lower your blood pressure overall. It goes up a little when you walk, but it's not going to go sky high typically, especially on the medicines Kim Eagle is putting you on. So good question.
Kim, this was, you honored us by that tremendous lecture, and, it's only fitting that you're here really honoring Larry, who's affected so many of us, and I've only known him a few years, so thank you, Larry. My question relates to the images you showed us, what I guess I don't know if it's still called this 4D imaging, using flow mapping of CT and MRI. Are you using that clinically now? It's been kind of a developmental issue for some time, but I haven't seen it kind of break through into the into the clinical world. So I'm curious if you guys are using that now to define risk.
Yeah, so it's a really good question, and we're not using it. The vascular deformation mapping I showed you, that technology you can use using standard images from any CT. So it doesn't take special image acquisition. So if we can prove that that adjustment in the phenotype predicts risk, it should be available and relatively inexpensive. The 4D flow with MR, that's tedious and not yet tied enough to outcomes that it's ready for prime time, and we don't use it for prime time. Great question. And I'm a bit of a dreamer, so that's just part of my nature.
Kim, wonderful work, lifetime of work, and thank you for that lecture. I wanted to ask about, so you've described what you've called, and we would all call the vulnerable aorta, akin to the vulnerable plaque that we can't necessarily see or know about. You described now a list of more than 30 aortopathy genes. I imagine those were found by whole exome sequencing, chasing. I'm wondering, in the context of personalized medicine, what would be great for all of us would be to be able to have these kinds of tests that you can't call them biomarkers, but have genetic testing be more part of our daily approach to clinical medicine. And I'm wondering how rapidly that expanding list is available to people for aortopathy gene panels that we might decide to send.
Yeah. Yeah, so the 30 gene panel is available, and usually the companies that are doing that, like Ambry and others, the charge is maybe $1,000. Many insurance companies will pay for it. Some won't, but they might give the person a voucher. So we can do that. Obviously, we have to get our patients to see a genetic counselor to help them understand the consequences of genetic testing. And the consequence that's most disturbing to them often is that we find a variant of unknown significance. So we don't find an FBN1 gene, we find an FBN2 gene, and we don't know what it means. And that's 3 times more common than finding the known pathogenic gene. So obviously genetic testing is very challenging because of the noise that surrounds it. But I think we're going to get much faster and much better in the next 10 years. I hope so. But it certainly, I don't know if any of you had patients come in and say, I really want you to screen me with, just screen my 30,000 genes, right? And I had a patient who owned 2 genetic testing companies who said, you need to do that. And I said, Ed, we're not ready for that. I don't think it's going to work. He came back the next year to clinic with a pile like that. He said, I told you. I told you. I got screened by my company, and I have 2 very important genes that predict cancer risk. I said, let me take that just into the clinic. I want to take a look at that. I came back and I said, Ed, you're right. They did identify those. Those cancers only happen in women. Okay. It's a problem, right? There is some noise. Anyway.
Well, with that, I want to again thank you for joining us today. And for those of us who are able to join you for dinner, I think it was going to be a wonderful time at dinner. And before we leave, and we should have done this earlier, I just want to also celebrate Dr. Cohen's life partner and partner in crime, who is by his side. And every time I see him is by his side. And I think without her, I don't think you would have done as much as you could have done. So I just wanted to say that as well, too, because we love having you here as well. Thank you. Okay.
And can I say one other thing about Jane? Larry would always show up with a white collar shirt and a perfect tie. And we felt like what he did, he went home, he didn't go to bed. You just hung him in a closet. And then he came back the next day. And you've been an amazing, amazing partner. Thank you.
Eric, I wanted to thank you for setting up this lecture, the honorary lecture, and the whole series over the course of the year. So this is happening because of you. And Kim, the American College of Cardiology really got it right this time, when they made you a master teacher. Because you've just given us a master lecture in aortic rupture, aortic aneurysm. And I think I'll never hear a more complete or a better lecture than what you've just given us. And lastly, I support Eric. You, Jane.
Thank you. It's great fun. Great fun. Great question.